Hi guys, welcome to my YouTube channel. So in this video I'm going to talk about the renal biochemistry. So if you haven't subscribed to my YouTube channel yet, so please go and subscribe and check my video. Hi guys, this is the part 3 of renal biochemistry. So starting with today's topic, regulation of GFR. So neural regulation of GFR and also the hormonal regulation of GFR. So GFR is regulated by a neural way and a hormonal way. So neural regulation of GFR will be from sympathetic nerve fiber which innervate in afferent arteriole and also the efferent arteriole, and these two both will form the glomerulus network of capillaries, and it will stimulate low but increase during the exercise and hemorrhage, and it will help in or do the vasoconstriction which will conserve the blood volume. So now coming to hormonal regulation of GFR, so it is done by various of them like angiotensin 2, which is a potent vasoconstrictor. That means it will constrict the blood vessels. ANP factor that is released by atria when stressed, and it will increase the GFR. Nitric oxide, bradykinin, and the prostaglandin E2. So now coming to autoregulation of renal blood flow, or we can say tubulo-glomerular feedback mechanism. So this is the mechanism by which there will be the regulation of renal blood flow and GFR. So first of all, suppose the BP is reduced, blood pressure is reduced, then the renal blood flow is also reduced. That's how it will reduce the BP. So GFR is also reduced and the flow of filtrate will also reduce. It will be like NaCl reabsorption from PCT will increase, then the NaCl reabsorption in macula densa will decrease, and when the NaCl reabsorption in macula densa will decrease, it will stimulate the JG cells, extraglomerular cells, to secrete the renin, and the renin secretion or synthesis will increase, which will allow to increase the synthesis of angiotensin 2, and we know angiotensin 2 is a potent vasoconstrictor. So whenever the blood vessel will constrict or contract, it will definitely increase the BP. So to reverse this case, then it will do the constriction of efferent arteriole, so that the improvement of renal blood flow and GFR will occur by increasing the BP. And if the NaCl is decreased in macula densa, then another response will be dilatation of afferent arteriole. So it will also help in the improvement of renal blood flow and the GFR. So this is the autoregulation of renal blood flow, or we can say tubulo-glomerular feedback mechanism. Coming to importance of renal autoregulation. So it will keep the tubular load of solutes, their distal delivery within the normal range to maintain the relative constant behavior of GFR and renal blood flow, prevent under due to retention of nitrogenous waste product and the fluid, and it will also prevent the loss of nutrients, and it will allow the precise renal excretion of water and solutes. So these are the important of renal autoregulation. Now what is tubulo-glomerular filtrate feedback? It is also called as glomerular tubular balance. So like afferent arteriolar feedback system, it consists of two arteriolar system: afferent arteriolar feedback system, in which arterial pressure will decrease, glomerulohydrostatic pressure GFR will decrease, proximal NaCl reabsorption will increase, then the macula densa will decrease the NaCl reabsorption, dilatation of afferent arteriole will occur, which will decrease the afferent arteriole resistance and will ultimately increase the glomerulohydrostatic pressure, that is the GFR. And another component to this is afferent arteriolar feedback system, in which the arterial pressure decreases, glomerular hydrostatic pressure also decreases, GFR also decreases, causes the proximal NaCl reabsorption increases, and then decrease the NaCl reabsorption in the macula densa, which increase the renin's secretion, and constriction of efferent arteriole will occur, and that's how it will increase the efferent arteriole resistance and glomerular hydrostatic pressure, and along with that GFR will also increase. So now coming to myogenic regulation of renal blood flow. So BP will increase when the when there will be a stretch to arterial wall, which will cause vasoconstriction, and then atrial natriuretic factor will secrete and renal blood flow will decrease. So what is limiting pH of urine? So lowest attainable urinary pH is called as limiting pH of urine. That means it is the lowest degree of pH attained by the urine is called as limiting pH of the urine. It is equals to 4.5. That means acidic urine or acidic pH of urine. At 4.5, the urinary pH rises to 40 micromole per liter, which is more than the intercellular hydrogen concentration of 40 millimole per liter, that is pH of 7.4 in the collecting duct cells. Against this used lumen gradient, H plus ions as intercellular pH is 7.4 to 8. Urine pH is 4 to 5, 4 to 4.5 in proton pump fails to secrete the H plus ions anymore to lower the urinary pH further than the pH 4.5 is the limiting pH. So this is the concept of limiting pH. Now coming to peculiarities of renal blood flow and their importance. So rate of blood flow is very high, that is 3.5 to 4 ml per gram per minute, that is 22% of the total cardiac output. So why it is important? Why this peculiarity is important? Because it will help to clear the waste. That kidney high pressure capillary bed, that is 60 millimeter mercury, that is hydrostatic pressure in the glomerular capillary is very high. So importance is facilitate filtration of the blood. Autoregulation of renal blood flow by kidney itself, so its importance is to maintain the GFR. Portal system containing glomerular capillary, that is responsible for filtration of plasma, and peritubular capillary for the reabsorption of desirable substance from the filtrate. And point number 5 is blood flow is selective and not uniform, that is 90 to 99% supplied to the cortex and 1 to 2% in the medulla. So what is the importance of it? So high blood flow in the cortex will allow the filtration, and less blood flow in the medulla will help in concentrated urine formation. So in vasa recta, velocity of blood is very slow and direction of blood is anti-parallel. Importance is create and preserve the medullary hyperosmolarity. Now coming to acidification of the urine. So the acidification of urine is the ability of renal tubule to reduce the urinary pH is called as acidification of the urine. Normal pH of urine is 4.5 to 8, and in case of vegetarian person it will be alkaline, that is 8, and rate of limiting pH is 4.5. That means this is the minimum pH attained by the urine. So major site of the urine concentration are distal collecting tubule, as non-volatile metabolic acids H2SO4, HCl, and phosphoric acid, lactic acid, keto acids are produced in the body, excreted through the kidney. The urine becomes the acidic. So urine acidification consists of 3 steps: secretion of hydrogen ion, proximal acidification, bicarbonate ion reabsorption mechanism, and distal acidification, that is bicarbonate ion generation mechanism. So now coming to secretion of hydrogen ion. So basic process for the acidification of urine is secretion of hydrogen ion, which is secreted by PCT 85 to 90%, that is by sodium hydrogen exchange, responsible for hydrogen ion secretion by the sodium hydrogen counter transport mechanism, and along with that DCT and CD will secrete most of the hydrogen ion by ATP driven proton pump here. Then the aldosterone will act as on this pump to increase the distal hydrogen ion secretion. So there are 3 important reactions in the tubular fluid with bicarbonate ion to form the CO2 and H2, with HPO4 minus to form H2PO4 minus, and with the NH3 to form the NH4 positive. So next step of urine acidification is the proximal acidification, that is the bicarbonate ion reabsorption mechanism. So in this concerned with the complete reabsorption of filtered bicarbonate ion of the filtrate, mainly from PCT and partially from the ascending limb of Henle, that is 10 to 20% from that, and from PCT 80 to 90%. Secreted hydrogen ion are titrated by this mechanism. So as you can see the diagram, this is lumen, this is cell, and this is blood. So in cell basically there is sodium hydrogen transporter, and from lumen a sodium molecule is coming in, sodium positive molecule is coming in, and in this there is the formation, and also the CO2 comes from lumen to the cell, which will form the CO2 and H2 inside the cell together form the H2CO3 in presence of carbonic anhydrase enzyme, which will give SCO3 minus bicarbonate ion and H plus positive ion, which will go out of the cell in the lumen, and in the lumen it will combine with the SCO3 minus ion to form H2CO3, which will give H2O, and from here it will give CO2 to form bicarbonate sodium hydrogen bicarbonate in the cell. and this is also the two transporter in which the 3 molecules of sodium ion will go inside the blood and 2 molecules of potassium ion will come return from blood to the cell along with bicarbonate ion, also the sodium ion. So normal tubular load of bicarbonate ion is about 4,500 millimole per day, when GFR is 180 liter per day and plasma bicarbonate concentration 25 millimole per day, that is 180 into 25, so about 4,500 millimole liter per day of H plus is secreted from PCT and ALH to reabsorb the filtered bicarbonate ion completely. Ultimate pH of filtrate reduces to 7.5 to 6.8 here. Now what is the feature of proximal acidification? Does not create the high luminal H plus ion concentration and creates a very low pH gradient by decreasing the filtrate pH from 7.4 to 6.8. So now coming to factor regulating the proximal acidification. Four factors that will regulate the bicarbonate ion reabsorption and H plus secretion. So high PCO2 will increase the H2CO3 synthesis and also the bicarbonate ion reabsorption. Luminal pH, which will high luminal pH attracts H plus secretion from the cells, and carbonic anhydrase will increase H2CO3 synthesis and dissociation in the cells. Along with that, angiotensin 2 will increase the bicarbonate ion reabsorption. So bicarbonate reabsorption mechanism characterized by involvement of SCO3 minus buffer, reabsorption of filtered SCO3 minus, no generation of SCO3 minus in the plasma, no net H plus excretion from the body. So now coming to distal acidification, SCO3 minus generation mechanism. So it is concerned with the excretion of NVA, that is metabolic type, accompanied by the generation of new SCO3 minus within the tubular cells with the addition to the blood. Secretion of H plus are titrated by this mechanism. Normal adult individual is about 70 millimole per day, and newly generated SCO3 minus absorbed retreated to blood to form replace the SCO3 minus eternally during the buffering and raise the plasma SCO3 minus to the normal. The H plus secreted in the lumen for the excretion with the urinary buffer reduces the pH from 6.8 to as low as 4.5. That is the limiting pH of the urine. So as you can see the diagram, this is the diagram by which the distal acidification will take place, in which the CO2 and H2 will combine to form H2CO3, which will give the bicarbonate ion SCO3 minus, so that it can give two things out, H plus ion and bicarbonate ion. It will go inside the blood, and along with the sodium ion it will go outside in the lumen, and in the lumen there will be NH3. So from the cell, NH3 will go to the lumen, which will convert to NH4 by getting H plus, and H2PO4 will have H plus and it will convert to H2PO4 minus. So HPO4 will be HPO42 minus, and it will have H plus, and this will form. So and sodium ion and bicarbonate ion will go inside the blood. So what are the features of distal acidification? That it creates a high luminal H plus concentration, creates large pH gradient by decreasing pH from 6.8 to 4.5. And what are the factor regulating? So the factor regulating indirectly will be blood pH and serum potassium level. Blood pH acidemia will occur and alkalemia will reduce, and serum potassium is hyperkalemia will decrease and hypokalemia will increase, and the directly regulating factor will be surrounding PCO2, which HPO2 higher, H2CO3 and luminal pH, which will increase the luminal pH, carbonic anhydrase, which will increase H2CO3 synthesis, aldosterone, urinary buffer, increase load in collecting duct will increase the HP secretion from the cells. So this was all about the distal acidification. Now coming to filtrate dynamics. So it is again Pg plus pi b minus Pb plus pi g. So it is the filtrate dynamics in which Pg represents hydrostatic pressure in glomerular capillary, that is around 60 mm mercury. Pi b represents the colloidal osmotic pressure in the Momus capsule, it is 0. Pi b represents hydrostatic pressure in Momus capsule, 18 mm mercury, that opposes the filtration, and Pb and pi g will represent the colloidal osmotic pressure in the glomerular cavity, it is 32 mm mercury. So it will ultimately give the filtrate dynamics, that is around 10 mm mercury. So what is extraction ratio? Fraction percentage of arterial concentration of a substance that is incorporated into the filtrate by filtration through the glomerular membrane as well as the tubular secretion is called as extraction ratio. Extraction ratio is defined as arterial concentration minus the venous concentration, uh, division to the arterial concentration or by arterial concentration. So substance not allowed to incorporate into the filtrate shows similar concentration in the renal, arterial and renal vein, and its extraction ratio is 0. However, substance which is partially incorporated into the filtrate so extraction ratio more than 0 but less than 1. So what is the criteria of substance, the plasma clearance, which is used to measure the GFR? That it should be free filtered, no albumin bound, neither reabsorbed nor secreted by the tubules, not metabolized or produced by the kidney, non toxic. Now, what is the substance which fulfill the criteria and can be used for the measurement of GFR? So it will be insulin, mannitol, sorbitol. Creatinine is freely filtered and non-reabsorbed after filtration. But since it is due to some action secreted by renal tubule, creatinine clearance slightly 10% overestimates the GFR. In spite of that, creatinine clearance is regarded as measure of GFR clinically. So now coming to estimated GFR. So what is eGFR? eGFR is estimated GFR, which is measured by using 24-hour urine collection. So it is defined as eGFR is equals to K into 140 minus age in years into body weight in the kg. So K will be 1.23 in case of male and 1.04 in case of female, and by the serum creatinine level. So this is the formula by which we can calculate the eGFR. So how can we measure renal blood flow and renal plasma flow or by plasma clearance of pH? So in this, basically the formula will be renal blood flow is equals to M divided by A minus V is equals to UV by P. So here M is amount of substance taken by the kidney, A is concentration of substance, V is concentration of substance in renal vein. So this is the modified formula by which we can measure the renal blood flow and renal plasma flow. Now, what are the criteria of substance? The plasma clearance, which is used for the measurement of renal blood flow, are high extraction ratio, not stored in kidney, not metabolized or produced by the kidney, non-toxic. Now, what is pH? Para-aminohippuric acid. Substance which will fulfill these criteria can use to measure the GFR. So, RBF will be RBF 1 minus HC plus. So, HC plus is hemocritic value of the blood. That is 0.45. Renal plasma flow, we know that 650 ml per minute. So renal blood flow will come from this formula, that is 1200 milliliter per minute. Now, what is glomerular tubular balance? So it is the adjustment of proximal convoluted tubular reabsorption to match with the GFR. It's called as glomerular tubular balance. Absolute tubular reabsorption will increase and glomerular reabsorption will increase, which will decrease the GFR, and with decreasing the GFR and fractional tubular reabsorption remain roughly constant despite the changes in GFR. So it, first of all, it will increase the GFR, then colloidal osmotic pressure in peritubular cavity will increase, reabsorption from PCT will increase, and that will cause the normal solutes in water delivery distally. So it will be opposite in case of when the GFR will decrease. In fact, change in GFR tubular load of solute tend to change, but glomerular tubular balance mechanism keeps the distal solute delivery and urinary solute excretion normal till the tubuloglomerular feedback mechanism operates GFR. That is the function of individual part of nephron. So first of all, we will see the function of PCT. So PCT stands from proximal convoluted tubule. So it will primary selective. It will help in primary selective reabsorption and partial reabsorption of water by 60 to 70%, sodium chloride by 60 to 70%, and potassium ion by 70 to 80%, bicarbonate ion by 90%. So complete reabsorption of nutrient like glucose, amino acid, vitamin, predominant reabsorption of calcium, magnesium, phosphate ion, urea, uric acid, secretion of H plus organic acid, base, bile salts, and para-aminohippuric acid, etc., etc., and synthesis of ammonia from glutamic and its secretion as the NH4 positive. So now coming to the function of loop of Henle. So loop of Henle will help in the osmoregulation, that is osmoregulation of salt gradient and reabsorption of water by 10 to 20% from descending limb of Henle, and sodium chloride by 20 to 30%, and potassium ion by 20 to 30%, calcium and magnesium from ascending limb of Henle. So now we'll come to bicarbonate that escapes the proximal reabsorption. So ammonia that is generated and secreted by PCT lateral recovered to NH3 and deposited into medullary intestinal spaces. Countercurrent multiplier to generate the medullary interstitial hyperosmolarity to the hypertonic concentrated urine. So now coming to function of DCT, it helps in selective reabsorption. So the reabsorption of water by 5% by the ADH and NaCl 5% by aldosterone and calcium 5 to 10% by PTH and calcitriol. So now coming to functions of collecting duct. So primarily osmoregulation, water retention, and the reabsorption of water by ADS that facilitate the urine formation, NaCl 1 to 8% by aldosterone, and potassium in case of hypokalemia. Secretion of K plus or potassium by the aldosterone and H plus by aldosterone, thus occur acidification of the urine. So there will be the excretion of bicarbonate ion in alkalosis and ultimate responsible for the final qualitative changes in the urinary excretion. So now coming to dilute urine formation. So whenever the glomerular filtrate is formed, its osmolarity is about the same as plasma, that is 300 milliosmol per liter. Then in PCT, the water will reabsorption and little changes in the osmolarity. So filtrate remains isotonic to the plasma, that is 300 milliosmol per liter. Then in descending limb of loop of Henle, water is reabsorbed without the solid. Tubular fluid becomes concentrated with the tip of loop of Henle, that is 600 milliosmol per liter is attained. Then in the ascending limb of loop of Henle, the NaCl is reabsorbed without water due to the impermeability of ascending limb to the water. So osmolarity decrease at 100 milliosmol per liter and the tubular fluid become dilute. Then in collecting duct and DCT addition, reabsorption of sodium chloride and no water reabsorbed as impermeable to the water. So tubular fluid more dilute and excrete 20 liter per day or 16 milliliter per minute. Osmolarity is about 50 milliosmol per liter. So this is dilute urine formation. So now coming to formation of concentrated urine, that is conversion of isotonic glomerular filtrate to the concentrated urine. So when the body fluid or the volume decreases, kidney forms concentrated urine to conserve the water, thus regulate water and electrolyte balance. So basic requirement for forming for the formation of concentrated urine will be high level of ADH, high renal medullary interstitial hyposmolarity, and high renal medullary interstitial fluid that is produced and maintained by the countercurrent mechanism. So steps for the formation of concentrated urine will be osmolarity of glomerular filtrate is same as the plasma 300 milliosmol per liter. In PCT, 65% of solute in water are reabsorbed and osmolarity of fluid remains same as the glomerular filtrate, that is 300 milliosmol per liter. Then there will be the osmolarity of fluid flowing through the descending limb gradually increases due to surrounding interstitial fluid, that is 1200 milliosmol per liter by the countercurrent mechanism. In ascending limb of Henle, the tubular fluid dilute and impermeable to the water and NaCl diffuse out of the tubule to reach the concentration of 100 milliosmol per liter. In early distal tubule become more dilute impermeable to the water. In late distal and cortical and collecting tubule, osmolarity depends upon ADH level. High ADH level will be very permeable to the water as the ADH is antidiuretic hormone, so it will absorb the water, increase the osmolarity. In presence of large amount of ADH, inner medullary collecting duct highly permeable to the water and water diffuses until the osmotic equilibrium is achieved and tubular fluid have same concentration as renal medullary interstitial, that is 1200 to 1400 milliosmol per liter. Then when the ADH will increase, small amount highly concentrated urine will form. Completes our video on the topic renal biochemistry, part 1, part 2, part 3, and I hope you like this series and this video too. So if you like this video, then don't forget to subscribe, like and comment below. I will come up with the more video of this kind soon. Thank you.